Thank you, Chris, for being willing to talk with Ed and I. And this is AMAAS. Ask me anything about swallowing. And we are just going to give you the floor to ask us anything.
A little scary.
Oh no. Well, okay. Let me preface by saying that I've been in the field since about 1993, and I've worked in pretty much every setting there is, except maybe the prison system. And I took a long. Ed and I were colleagues a few years ago, and I had during a period of time where I took a long break from clinical work. When I had my kids and all that other stuff. And I was actually seriously burnt out. I had been working in the SNF for a really long time up to that point and just needed a break. I got back into clinical work last year, and I thought about going back to the SNF, but decided to try home health, which was a setting I hadn't worked in regularly. I had experience, but not a daily experience. And so that's what I'm doing right now. And I love it. I actually really enjoy the setting. But there are a number of challenges treating both communication and swallowing in that setting. So one of the things that I find, like right off the bat, and Ed, you know this, right off the bat, you tend to not get good documentation when you get your referral from the home health agency. So most of the time I don't get a copy of a swallow study if one was done. So I have to dig through the records to see if someone mentioned it somewhere. I'm in the Richmond, Virginia area, and we have about 15 hospitals. So there's a lot of options, in terms of getting instrumental studies done. But frequently what I find is I don't get that information. So, this isn't really a question so much as a statement of, chasing. One of the barriers to working well and efficiently in this setting is chasing down the information that you need from multiple other sources. And then aside from that, in the home health area, we don't tend to have a lot of access to instrumental evals, but also to any other treatment strategies that might involve e-stim or other devices for measurement, for treatment. And so a lot of what I'm finding myself doing is nightly research, trying to find the best techniques that I can use based on either what I finally do get when I get a swallow study or clinical judgment, which is not, it doesn't sit right with me because I don't have the information I need. So I think one of the things that I struggle with the most is how do I make these clinical decisions when the pieces aren't even there to begin with? And then when I have to spend what I would consider an excessive amount of time either chasing them down or setting them up, set up an instrumental or call various therapists to get, that information. That's where I'm stuck a lot of the time.
So can I, obviously you've been with this home health agency for a few months, not for an extended period of time. Right. Have you considered having a meeting with the agency and setting expectations for what you need in advance of seeing a patient? Before you give me the referral, these are the things I need.
Yeah. And I have initiated that. I'm actually a PRN therapist, so I work for 3 agencies. And at least one of my agencies is very receptive to that sort of, here's what I need. So I think in at least one agency's case, I do have some control. So while I was thinking about this yesterday, I'm actually I emailed my supervisor for that agency to see if we could sit down and talk about how the intake process could be a little bit smoother in terms of getting the information for me.
So what about the other two? What about the other two?
I was going to say, I have the other two agencies that I work for. One has a very, very well established pair of speech pathologists who are wonderful people, but who are pretty, I want to say, stuck in the previous generation of thinking about swallowing. So I get a lot of I don't know if you're familiar with home care, home base, but the program that you use for documentation in healthcare, in home health, that there are two therapists who've been with this agency for a very long time, and one of them set this program up. And so it pops up things like goals for thermal stim, goals for oral motor exercises, goals for things that we know are not effective treatment. So that is going to be a bigger issue to kind of work around. Do you know what I mean? Instead of, I'm new and I don't want to be like, well, you're doing it wrong, even though.
So go ahead.
Okay.
Well, do you want to continue on your line of thinking and then I'll jump in with mine?
Well, what I was, again, as far as, agency. So have you considered requesting a meeting of the speech pathologist to talk about practice patterns and to talk, maybe set up a journal club or maybe set up monthly meetings to talk about advanced information in swallowing? Because I think it's funny, often people will say, well, they're stuck in the old way. And it's really funny because I'm preparing to teach a class right now. And in 1976, Jerry Logeman said, don't treat swallowing without imaging.
Oh, I know.
And I can't imagine that there's any older than that.
Well, but you know what I'm,
I understand what you're saying, that there are clinicians who have bastardized the information and moved forward,
right?
Because they've validated their own position because maybe the imaging was difficult, as you said. Mm-hmm. And so they've tried to validate their practices by changing them and morphing them into something different that's easy for them. But if we really talk about old school, George Larson was first and he was the artistic kind of person, but Jerry Logeman was second and she was no imaging 100%. And so the foundation of this is not what they're practicing.
Right, exactly. And I was lucky enough to take her, Jerry Logeman's course way back, when she was still teaching it regularly in the 90s. And I remember that. And in fact, I probably still even have my notes. But yes, but you understand what I'm saying, where clinicians have sort of gotten away from doing the imaging or feeling that the imaging was a necessary, absolute thing, and are providing off of a clinical bedside eval.
Right, but I guess my question to them would be, where did you learn this, or why do you think this is okay?
Right.
I think so. Can I jump in here? Because
sure,
Jerry may have said do it, but it was never happening widespread ever. So just because the old way was something that was stated, that's like saying all men are created equal at the time of slavery. And just because they said it, it doesn't mean it was officially the old way or even the current way, right?
Right.
So it's always been a principle that people thought would happen. The old way is exactly what they're doing in terms of what people were doing. So they learned it from generations before them and generations before them. And I appreciate talking about, well, what can we do to get to best practices? But best practices isn't only, do you have instrumentals and are you use them? Let me ask you this, Chris. Are you allowed to do clinical swallowing evaluations?
I am.
Okay.
I don't do
so,
Go ahead. No, go ahead. Finish yours.
Yeah, so that is within your purview. There are no barriers to you being allowed to do that when you walk in to a patient setting and say, hey, my name is Chris and I'm here to help you with your swallowing and maybe some other things, right? You could say the first thing I'm going to do is a clinical swallowing evaluation. Fair?
Yeah.
Okay.
Absolutely.
So can we talk about all the things you actually can do?
Yeah.
Because if you do a clinical swallowing evaluation, what are the kinds of things, let's talk about the things that you can gather from that's reliable.
Okay.
And the things that you can't. And when they say, hey, how come you're not working thus? You say, so these are the things I can work on.
Mm-hmm.
And instrumentation is necessary for those. And then don't touch them.
Right. Okay.
So let's talk about some things that we can do.
Okay. Well, when I try to do as, it's not really standardized, but I try to do as consistent a measurable assessment as I can. So even to the point of having the syringe for liquids and measuring different amounts, 5 ml, 10 ml, and things like that with patients, I do that. When it comes to solids, I use a more like natural, like show me how you would eat this, um, especially because I really believe that people should try to get as close to their normal behavior, what they do, as possible. So I can I can make a statement about whether or not there's a possibility of food or liquids getting into the area, but I can't say for sure. I can talk about a patient's oral control of the bolus insofar as I can see it from where I sit. Is it falling out of their mouth? Are they getting food everywhere? Is stuff getting pocketed down? When they swallow, are they piecemeal swallowing, or do they seem to be clearing the bolus? Are they able to chew a solid bolus adequately? Now, adequately drives me bananas as a word, because like, what is adequately? So I try almost never to use that statement, and I'm still working out the what kind of language I want to use to describe that. So if you have a suggestion, I would love.
Yeah, no, let's take what you said so far. So one thing that I love that you already established is there are things that are sort of gray areas that you can approach but can't confirm. But let's talk about the things you can absolutely confirm that you are primed to do that no one else is. You get to walk into their natural environment, right? And really see what their world looks like, what they like to eat, how they like to eat. You get to see them in a family setting. No other discipline, no other setting gets to do that. We get to see functional eating, and we get to sit down with them for extended periods and get into their world and sit at the kitchen table with them and say, let's talk about what you want. And they might even point to things and say, this is my favorite cereal. I want you to help me to eat this. Do you have strategies? So this is what you can do. This is where I think home health should be focusing on. Not, I want to attach these electrodes in the absence of imaging, and I need the technology. To me, just like every other discipline, the farther away you get from the hospital, the more functional the goal should be, the less clinical and medical it should be, right?
Yep.
If I'm a PT going into somebody's house and I see, oh, you've been following, oh, you have that very thick shag carpet, I understand. Let me give you strategies in the absence of removing that barrier, right? So to me, that's where we're supposed to be. And there are certainly some things that you can do, like really, really good sensory testing, which is often ignored. We don't need anything special for that. There can be things that we can do in terms of involving caregivers and helping them to reinforce real strategies, real clinical ideas that we can implement in that setting. So I would say that if you take the home healthcare setting for what it can be and not apply it to what, acute care people would think I'm basic because I am not blah, blah, blah. You're not basic. What you are is you are somebody who's saying, I'm skilled in the setting, given what the setting calls for and what these individuals need from me. So I would say, let's shift our thinking to applying our skills to the setting and the population that need us to be in this domain versus that domain. What do you think?
I think that's fantastic, because that is actually where I'm trying, and I'm glad you said it and framed it the way you framed it, because that's one of the reasons I love the home health environment so much, is because we're out of the sterile hospital. We're away from people being angry and pissed off in the nursing facility. You know what I'm saying? It's like you go into the nursing facility and everybody's angry because they don't have their clothes, they don't have their books, they don't have their whatever. And so, when I go into the home setting, I have a clinical example for you that is recent, and I don't know if I made the right decisions here, but they seem right to me based on his situation. So this is we have an 83-year-old gentleman, sweet guy, above the knee amputee, wheelchair, vest. He's in the chair, and he was ill. whole bunch of medical situations. He's on a fluid restriction, but it's not a massive restriction. I can't remember off the top of my head what exactly it is. But when he was in the nursing facility after the acute stay, the speech pathologist there, to my knowledge, did not do a swallow study, so there's no evidence. But he was coughing on some thin liquids, which was the only texture that gave him any sort of trouble that she assessed. And she gave him one of the flow limiting cups, with the blue, and he is alert, cognitively intact enough to follow directions and know what he's doing and participate in therapy and in his meals. But this cup was driving him bananas, because when I looked at it, and I haven't used them ever actually. And when I poured the amount out that he was receiving, he was getting like a cc at a time. Like they had set it for some ridiculous, it was crazy how little he was getting. And he was like, "You've got to help me drink. I'm thirsty." So I tried various heights of cups. He seemed to do better with a shorter cup that he didn't have to tip his head back. And I taught him to, take his time and take some small sips and make sure he swallowed and didn't gulp down a huge amount and didn't use straws. And he has a little bit of, every once in a while, but nothing major. And so and he's 83, and the family was like, here he is, and we don't really want to do a whole extra bunch of stuff with him. And I'm like, okay, so their decision was to not go for a swallow study. I presented the options, and it's fine with me. They chose not to. And that he's happy. He's drinking his liquids. He's being careful. Loves his little open cup that we picked out of the cabinet.
So,
what else?
yeah.
You did your job, Chris.
Yeah.
You went in there and you have the capacity to hyper medicalize the situation.
Right.
You could have gone in there and scared the crap out of the family and say, "No, we want to squeeze 2 more years out of grandpa. Let's get him happy." Guess what? You went in there, you said, "I could have gone this direction, but what do you want? And how can I help you do the thing you want to do better?" Which is get more fluid out of this cup. Here's what else you have that you can do, and I'll pass it on to Ed and shut up a little bit, is you get to not only walk into their natural environment, but you get to get a real sense of how they look in terms of health. I'm not saying that you get a blood draw number by looking at them, but you get to see, is this person able to even to get up? Are they weak? Are they able to communicate with me? You're getting some general information, and you can use their chart to get information about hydration and nutrition before you get in there. So you can say, if this person wants to get more fluid, I don't see a problem with that. What's their general medical status here? And I'm going to use that to drive their request. Now you walk in there and the person looks really sick and their numbers are really off. And you might say, "You know what, this is what I'm seeing. I would recommend this other intervention, but of course it's still their choice." And maybe you would push in that direction a little bit more. But what you've done sounds to me exactly what I would expect a functional home health clinician would do in this situation. Ed?
Right. So what I was going to say, yeah, of course, if I'm going to actively treat people, I want to know what's wrong with their swallow. But this was someone who had a goal that they already knew. I want to drink more. I want to have this. I want to eat these things. It wasn't about, I want to stop coughing or I want to have a perfect swallow. It was about a functional goal. And you met that functional goal. I would agree that in this case, that was the perfect thing to do. We don't eat to have a perfect swallow. We eat to enjoy the food, to socialize with our family.
Right.
And I agree that you probably couldn't get away with that in another setting.
Well, and
people would be upset. "Oh, he's still coughing," and you would get, someone would call you every day, a nurse or someone.
Right.
But in this situation, it was perfect.
Well, and that's the thing, making the shift. And since I have, years of clinical experience, it's like they're always, those other settings are always hanging out in the back of my head. It's like, oh, if I was in the hospital, or if I was at the SNF, the nurse would be running down the hall, they're still coughing. And I'm like, well, I choked on a mouthful of wine last night. So like, what, yes, we all, there is always some level of normally functioning person who's going to get it down the wrong pipe and That doesn't automatically mean pneumonia, and it doesn't automatically mean that there's a huge issue. So I think it's been really helpful, Dr. Humbert, for you to frame my work in the way that you did, because it makes me feel more confident that my functional approach not only makes sense in the setting, but is appropriate in terms of best clinical practices.
Yeah.
You know,
and I will, go ahead. Sorry. Were you going to
No, it's fine. When I started working in home health, it was in the fall, and I had, distant rural patients. So I was driving a lot. So I was listening to podcasts, and, you could kind of drive yourself bananas with the podcasts. I would listen to you, and I'd listen to a couple of others, and I was like, oh my God, I'm not practicing at the top of my license. And I'm like, but I am. I mean, in the sense that
in your setting, you are.
right. And maybe that's where, maybe it's not so much getting the information, like we were talking about, getting the swallow studies and getting the data and getting the this and that. Maybe the reason I enjoy this setting so much more is because it's more holistic.
Yeah.
And it's more functional. And it's so good to be able to say to a patient, well, let's work on what you want to do and what's going to make you feel good here in your home, while you're recovering. Or
your body, your decision, right?
Yeah.
Everything you said is great. I'm glad you guys touched on other medical specialties making decisions for us that we wouldn't make if we didn't have to. That's an important benefit of home health. You get to be more autonomous and really listen to the patient and what they want. But you also said that you have more confidence, and then I want to go back a little bit to what you said about the other people practicing in the dark ages. Also remember that these are people who are probably clinging to the things that they're doing in medical facilities because they feel like they have to. Like they feel like they're bad clinicians. And really, all they need to do is reframe their thinking about what a clinician in this setting should be doing versus a clinician in that setting should be doing. And you might be able to say, look, all of those physiologically based techniques that you're doing in this setting to try to adjust the tongue a little bit and so when you don't know what it's doing might not be doing much more than acting like a feeding consultant across the age span, which is what we end up being. If you have a lactation consultant, go to a mom's house who hasn't nursed before. This person is going to really take in the environment very differently from a NICU nurse who notices a baby isn't latching properly and has failure to thrive. And you know what? They're both appropriate. So maybe what we should be doing to increase confidence in your colleagues and give them an alternative and increase their sensibility that, no, I do bring skill here, is to bring in that functional concept that you've been doing instead of saying this is what you're doing wrong.
Right. No, I completely agree. I think that, and I don't want to be in the position of looking at other therapists that I work with or that I'm, associated with and say, this is wrong. I mean, nobody's hurting anyone. Do you know what I mean? It's not right. I mean, but I don't want to be in that position. That's not my role. I want to help people.
But how about using your influence? And it's not about people. When we have discussions, it's never about you and me. It's about ideas and concepts. Right. If we do it well. But again, having discussions. And when I said about a journal club, it doesn't have to be about, well, here's an article about the efficacy of effortful swallows, but it can be about quality of life. It can be about really understanding aspiration pneumonia, so we're not so afraid of people coughing in our presence, and and talking about quality of life over technique.
Yeah, getting into the technical details. And that's interesting because, well, years ago when I thought that I wanted to try to study for a PhD, one of the things that I was really interested in is the ethics around swallowing and the functionality around people and meals and eating and like what all of everything that comes with that has very little to do with the physiology of swallowing. Do you know what I mean? Like, tube feedings in the elderly, peg tubes, for people with dementia drives me insane. You know what I mean? So it's like those kinds of things that really interests and fascinates me, like the discussion around quality of life, because meals are so critical.
Mm-hmm.
Eating together is such can be such a life affirming and community affirming activity.
Yes.
That I want to be in a position to not take things away from people. Oh no, you can't have that. Nope, you can't have that. I want to be in a position to say, look, let's facilitate, the best possible situation for these patients.
We have only a couple minutes, and first I just want to thank you for being so candid and open and just willing to say, hey, this is what I don't know and this is what I do know and that kind of stuff. But importantly, I just want to end by saying folks in home health have the opportunity to educate everybody else about what happens by the time they get to you. One, which is you can look at a chart that has all the information, said they went through all of this, and at the end of the day, it didn't matter, or it did matter, right? That's one. And two, the other thing that you guys can help the other settings with, that you have a prime opportunity, is the cultural diversity associated with feeding and eating. You guys get to see individuals in their home. Maybe you're in a rural setting, maybe you're in an urban setting, and understanding what it means to get maybe to get this fresh vegetable and all the process it takes to get it down to a chewable thing versus a can, and how people feel about those kinds of things, how people feel about eating in front of strangers. And there's so many things that you guys can inform us about, and the extent to which they believed that speech therapy helped them to improve is so much of a bigger deal than anything else. If somebody thinks that a specific branch of a profession is a fraud, which I'm not saying they think that about us, but if we determine that, you're the first SLP that ever listened to me, all the ones in the hospital never listened to me, that's still useful information. And I would, since you have a general interest in this, remember your clinical evidence is as important as my research evidence. So you might not have might not have completed a PhD, but there's no way that I could ever do a study that's as realistic as the kinds of questions and information you're gathering that I would call hypothesis generating research, right? Meaning you're gathering real world information about real patients in a real communication setting, and it's so much more generalizable than the deconstructed, validated questions I would ask to a certain population that has access to somebody like me. So keep that up.
I will. I really appreciate your input, and you too, Ed. Because
collect your data, Christine, and let us read something that you've written about what you're doing in this setting and how the services of a speech pathologist can improve quality of life.
Yeah, and I'm happy to contribute in any way I can if that's something you end up doing, or just read it or just champion you.
Yeah, I would actually, I've been thinking about, like, I always end up with ideas at the end of the day after seeing my caseload of things I want to like talk about. Do you know what I mean? It's like, okay, here's the situation I encountered today. Let's talk about what this really means for this patient. Like, besides all of did you mark down how many times he coughed and what, and I'm like,
well, you're really engaging. So you might consider something as simple as turning your laptop on when it's fresh in your mind. Maybe you're in your car, maybe you're at home, and just blog it out. Just say, okay, guys, this is what happened. I saw this, and you're not going to believe blah, blah, blah. And I wish I could have been more helpful, but blah, 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 blah. And then just leave it all on the recording.
That's a good idea. I think I might try that. Yeah.
All right. Well, thanks for joining us.
Well, thank you for having me. I really, really appreciate being included in these discussions. They're very helpful for me, and I hope that they'll be helpful for other people, especially clinicians in my setting, because it's definitely different than the typical medical settings that we work in.
Yeah.
So it's great. Excellent.
All right. Any last words, Ed? Ready to sign off?
Thanks, Christine. It was great to talk with you.
Good.
Okay.
Good to see you.
All right. Bye, everybody.
Bye.